Hello, this is a virtual microscopy cytology slide from a thyroid FNA from a right thyroid nodule in a middle-aged lady. So at low magnification, it is extremely cellular. We can see that there are many cohesive sheets of cells, and there are some looser, smaller sheets of cells in the background. At this magnification, we don't see abundant colloid. Zooming in into this air-dried smear, we can see that the sheets are composed of very cohesive cells with somewhat eccentric, rounded to slightly irregular nuclei and scant to moderate amounts of fairly homogeneous cytoplasm. The looser groups of cells appear very similar to the larger tissue fragments. And as we look around, we can also see that there are some smaller nucleated cells with small round nuclei. There is a group of cells here where the nuclei are comparable in size to those of red blood cells, and this group is a group of follicular cells. The usual size of follicular cell nuclei is just slightly larger than red blood cells. And here again is a group of follicular cells. In this field, we can compare the follicular cells with these other cohesive sheets of cells, and we notice that these cells are much larger than the follicular cells. There is also a foamy macrophage here. So the predominant population of cells here is that of large cells that are significantly larger than follicular cells. And again, if we make the side-by-side comparison, we can see that these nuclei are larger and the cells on the whole are also larger. So this may represent a malignant primary or potentially a malignant secondary tumor. In terms of primary tumors of the thyroid, of course, the most common is papillary thyroid carcinoma, so we need to take a careful look at the nuclear features on the alcohol fixed smear. There is some material in the background which resembles colloid, and indeed it may actually represent colloid because we do have thyroid parenchyma in the background. Let's take a look at the alcohol fixed smear. And again, we can see that this is a highly cellular smear with these large cohesive sheets of neoplastic cells. And at this magnification, we don't see any definite papillary tissue fragments with fibrovascular cores or branching papillae. These cells are arranged in very cohesive, crowded syncytial sheets. Here we can see that there is a sheet of thyroid follicular cells with round nuclei and somewhat granular chromatin and small nucleoli. And we can compare these with these larger lesional cells. And again, we can see the size difference. Looking at the nuclear features, there is an occasional nuclear groove. However, the nuclei of these large abnormal cells do not appear to have ground glass chromatin. The chromatin is somewhat coarse in some of the nuclei, and we can see variably prominent nucleoli. And here again, we can actually appreciate that there are two populations of cells in this single sheet. We have the smaller follicular cells and we have the larger neoplastic lesional cells. Other malignancies to consider would be medullary thyroid carcinoma, which tends to be more discohesive and also have a stippled chromatin pattern, which we don't really see here. and this is not pleomorphic enough for anaplastic thyroid carcinoma. Hence, one possibility to think of is metastatic carcinoma to the thyroid gland. In this field, again, we can see a side-by-side comparison of two very different looking populations of cells. On the right, small thyroid follicular cells, and on the left, this population of malignant epithelial cells. And this is a case of metastatic breast carcinoma to the thyroid gland. Hence, it would be very important in such a case where there is an index of suspicion from the morphological features to look up the clinical history. And this patient has a history of known invasive carcinoma of the breast, no special type, and has a thyroid nodule. Some clues morphologically would include the absence of convincing colloid, particularly around the lesional cells, and also this population of malignant cells that does not fit into the common known primary thyroid malignancies. Let's look at one other example of metastatic breast carcinoma to the thyroid gland. Here is another example showing the air-dried smear. Again, we can see two populations, the larger malignant cell population and the smaller follicular cell population. These malignant cells are very large compared to the thyroid follicular cells. In this case, some of the malignant cells contain cytoplasmic vacuoles. And this is the corresponding alcohol fixed smear, where again, focusing up and down, we can see clearly this larger cell population of malignant cells in contrast to the follicular cells. These malignant cells have large nuclei, relatively pale cytoplasm, and coarse chromatin. So in summary, this is an example of metastatic breast carcinoma to the thyroid gland, and the cytologic clues will be the fact that there are two cell populations, a clearly benign thyroid follicular cell population and a second malignant cell population, and usually the malignant cells would be significantly larger than the thyroid follicular cells, which are generally quite small. If these malignant cells do not fit into the morphological features of the usual types of thyroid carcinoma, for example, papillary thyroid carcinoma, medullary thyroid carcinoma, anaplastic thyroid carcinoma, then the possibility of metastatic carcinoma and a relevant clinical workup should be done. Immunohistochemical markers can be very useful and confirmatory on a cell block if available. For example, in this instance, GATA3 or mammoglobin can be performed. Thank you.